Good morning. So I just sat through that last session and wondered in what country I was, because the experience and the optimism is certainly new to me. My primary care physician happens to be, by accident, the head of the weight loss clinic at the University of California, San Francisco. And if you want to bring her to tears, just talk to her about access to, in fact, GLP-1 drugs. So I'm going to talk to you today about how to change US healthcare. And the way you change US healthcare is by starting with the employers. Over the last 5 or 6 years, I have begun working on a book which hopefully will be finished relatively soon to talk about, in fact, how to make the US healthcare system work better. In this research, I have discovered 2 overriding principles. The first principle is one person's waste is someone else's business model. There's a lot of friction and a lot of waste in the US healthcare system. But there are companies that are making a fortune out of that. And so therefore, the change is going to, I think, come with great difficulty. And secondly, and very consistent with the eMed message, prevention is a lot less expensive than remediation. So I'm going to tell you what you need to do, and I will end with a story which describes, I think, what the barriers that we have ahead of us. Oops. There you go. So, first of all, I think employers need to recognize that no matter what business you think you're in, all employers are in the healthcare business. And they're in the healthcare business for 2 fundamental reasons. Number one, what happens at work profoundly affects people's health. In 2018, I published a book entitled Dying for a Paycheck, which talks about the connection between the workplace, management practices, and human health. Long work hours, workplace stress, workplace depression, work-family conflict actually have health effects. Almost everything that goes on that we studied in the workplace has a larger effect on health than secondhand smoke, a known and regulated carcinogen. And secondly, we're all in the healthcare business because employers are providing healthcare. If you're a large employer, you are self-insured. If you're a mid-sized employer, you are still probably self-insured. But employers provide medical benefits. Employers spend about $1.5 trillion a year on employee benefits. So we are affecting people at work, and we are affecting people through the health care that we provide. Health matters for numerous outcomes. It should not be a surprise to anybody, and I should not have to give you data, though I will give you some data, that a healthy employee is less likely to be absent, less likely to quit, more productive, and, of course, more creative. It is interesting. I want you to put yourself today. I'm going to make you, for the moment, the general manager of the Kansas City Chiefs, Patrick Mahomes. You are concerned with Patrick Mahomes' physical and behavioral well-being because Patrick Mahomes is the key to your success. If Patrick Mahomes comes to you and says, "Coach," or general manager, "I have a pain," you are not going to say, "Patrick, let me get prior authorization to see whether or not we can examine you." You are not going to say, "By the way, this treatment is outside of our budget." You are going to do whatever you need to do to keep Patrick Mahomes healthy. The Patrick Mahomes example, of course, is a little bit overstated. But in fact, the message is exactly correct. Your productivity and success of your company depends upon the health of your workforce. And the third piece, which is another piece which is very important, is that behavioral and physical health are related. We are spending a fortune on health in this country because, why? Number one, not enough emphasis on primary care. I come from Stanford University, a wonderful and fabulous institution, which has a fantastic medical school and an enormous hospital. I have a very dear friend, Amir Dan Rubin. When Amir Dan Rubin arrived at Stanford Healthcare to become the CEO of Stanford Healthcare in 2010, Amir Dan Rubin did something extraordinary in the history of Stanford Healthcare. He introduced primary care. Why is Stanford Healthcare so expensive? Because we have more than 1,000 specialists and 50 primary care doctors. Why is Kaiser efficient in delivering health care? Because it's completely flipped. Kaiser, primary care first. Why is there so little emphasis on primary care? Follow the money. We don't pay enough for primary care. Primary care doctors are burned out and they are leaving. Second, there's not enough emphasis on prevention. A message that I should not have to give in this. You get paid for treatment. You don't get paid for prevention. And three, too many intermediaries. Eric has already talked about the administrative burdens in the United States. More than 25 years ago, Steffi Woolhandler and David Himmelstein published an article which talked about why the U.S. healthcare costs so much. 25 to 30% of the U.S. healthcare spend, that's trillions of dollars, spent on administration and fraud and waste. And finally, there's an inadequate measurement. I have gone out with my colleague Sarah Singer from Stanford Medical School, and we have surveyed benefits administrators around the United States, and I can tell you there's no measurement, and there's essentially no accountability. With no measurement and no accountability, you get no performance. And that's why U.S. healthcare is so expensive. That by the way, means that it would be easy to fix. All you got to do is measure and manage. But we'll talk about why we're not doing that. Work environments affect health. Layoffs affect health. We announce layoffs every day. Do you know if you are laid off, you are twice as likely to commit suicide? That's a true fact, done in studies around the world, not just in the United States. Do you know that layoffs increase the likelihood of cardiovascular disease, depending upon the study, by up to 40%? Work hours affect health. Classic studies should demonstrate that beyond 40 hours, every 5-hour increase in work time monotonically increases your risk of high blood pressure. Work-family conflict increases ill health because of stress. The absence of job control. The famous Whitehall studies done many years ago by the British epidemiologist Sir Michael Marmot found higher your rank in the British civil service, you'll lower your risk of cardiovascular disease. Why was that? Because your higher rank in the British civil service, the more control you had over the conditions of your work. Health benefits and access to health care affect health. Even though, look at the KFF data, the Kaiser Family Foundation data, even though most employees work in companies that do provide health care, not all employees access health care. It's only about 60%, because in some cases there are eligibility requirements. You've got to be here 6 months or a year in order to access our health benefits. And in some cases, employees cannot afford the health benefits because, of course, over the years, as healthcare costs have gone up, those costs have been shifted to the employees. There is a connection between physical and behavioral health. For many years, it was hard to get treated for mental health, stress, and depression. It still is, even though because of Al Gore and his family issue, there is supposedly health equity. If you go talk to anybody delivering behavioral health, they will tell you that equity is in name only. It's not real. However, there is a huge connection between physical and behavioral health. There is a link between depression and stroke, all-cause mortality, coronary artery disease, and chronic disease, including cancer. And how is that connection made? It's through, number one, health-relevant behaviors. It turns out if you're stressed and depressed, you're more likely to smoke, you're more likely to drink, you're more likely to do drugs, you're less likely to exercise, and you're more likely to overeat. As one famous psychiatrist said, we call it comfort food for a reason. People respond oftentimes to stress and depression by eating. And then there's now studies that are coming out in medical journals that say because of the stress and depression affects the central nervous system, which in turn affects the regulation of hormones and your metabolic system. So, for instance, a meta-analysis of 58 studies found connections between depression and blood markers and inflammation, which means that if you are going to be serious about health, you need to worry not only about physical health, but behavioral health, because the two are connected prospectively. Employee health effects, as we've already talked about, absenteeism, turnover, productivity, and performance. A study of 2,300 employees linked biometric factors significantly to long-term absenteeism. Turnover, employee mental and physical health plays a significant role in intentions to leave. You do not do your best work if you're not feeling your best, both behaviorally and physically. And of course, creativity requires you to be at your best. We are spending a fortune. Everybody knows this, 18%. Per capita spending is high. We are spending more than any other country. That is in part because we have an enormous administrative burden. And our health outcomes are bad. I don't think most people in this room actually understand how bad the United States health outcomes are. So I'm going to cite you from an article entitled Missing Americans, Early Death in the United States. This was published in the Proceedings of the National Academy of Sciences. The study is easy to describe. It took an enormous amount of work to do. A bunch of people got together and said, mortality tables have been available for advanced industrialized countries since the 1930s. Let us take 21 countries that are rich like the United States, the United Kingdom, the Scandinavian countries, Australia, New Zealand. Let's look at their mortality tables and let's average them. And then let us apply the average of the mortality tables of these 21 wealthy countries to the United States population, starting in the 1930s and going to 2021. And if you apply the mortality tables to the United States, you get predicted death, and then you can compare predicted death to the actual death rate in the United States. And what you will find in the 1930s and in the 1940s and the 1950s and up into the 1960s is that the US did better than our comparative countries. Starting in the 1970s and 80s, about the same. And now, of course, we're doing worse. How much worse? In 2019, there would have been 622,000, let that number sit with you, fewer deaths if the United States had the mortality experience of its comparative countries. 25% of all US deaths, excess deaths. Under 65 mortality, half of all US deaths for people under 65 would have been avoided if the US had the mortality rates of its peers. And what about the increase in deaths during COVID? Between 2019 to 2021, 90% of the increase in deaths for people under 65 years old in the US would have been avoided had we had the experience of our comparative countries. So when you need to understand how badly the US health system is performing. You can go to the World Health Organization. Not to believe me, I'm a professor from Stanford, can't be trusted. You can go to the World Health Organization. The United States does not rank in the top 30 countries on any measure of health system performance. We should be ashamed of ourselves, and we should do something to fix this. We're spending a ton and getting nothing, which means that the US healthcare system is woefully inefficient because you're putting in inputs and not getting proportional outputs. Because there's an employee feedback gap. A survey of more than 200 benefits HR people that my colleague Sarah Singer and I did found that 39% of all employers never, let me emphasize the word never, ask feedback from their employees. Minimal assessment. We ask people, what do you measure? And the answer in one word is essentially nothing. Only 8% of all the companies that we surveyed assessed the time spent on benefits questions. And fewer than 5% asked their employees whether or not they had to forego filling a prescription or seeing a doctor because of cost. On average, 64% of the 15 health benefits performance dimensions were managed by no one. If you have no measurement and if you have no management, it should not surprise you that you have no performance. This is true for health. It is true for everything. By the way, the solution, therefore, is measure and manage. It is as simple as that. And we could have long discussion about why employers aren't doing this. The administrative burden of US healthcare is enormous. The US spends approximately 20% of health expenditures on administration, not counting the more than $26 billion in employee time spent on the phone with benefits administrators. We have intermediaries. And you all know the names of the intermediaries. What do the intermediaries do? As far as I can tell, the intermediaries do nothing. Intermediaries go out and negotiate network pricing. However, peer-reviewed studies in medical journals find that in about 50% of all cases, the cash price, do you have a Visa card? If you have a Visa card, you can do as well. Is that no? CVS, who I know is probably here. The cash price is cheaper than the negotiated price in about 50% of the cases. Why is that? Because 17% of all approved medical claims are never paid. So if I come to you, if you're a hospital, and say, I'm going to pay you cash, number one, you save the billing problem. But number two, you actually know that you're going to get paid. 17% of all approved medical claims are never paid. That's why people take cash. Study came out just recently in a peer-reviewed medical journal. Approximately $30 billion is spent on prior authorization, which, by the way, do not save money. Why do prior authorizations do not save money? Because while you are going through the problem and the task of getting prior authorization, the disease, in fact, is getting worse. There's a peer-reviewed study in a medical journal that talks about the particular kidney disease that besets kids. And it turns out what happens, the longer the delay in treating the disease, the more expensive the treatment. So while you are doing prior authorization, the disease is progressing, let alone the stress and everything else. The administrative burden, so what are we doing? I'm putting you through prior authorization. I'm not paying claims. I'm burdening you with paperwork, which has, by the way, simple implications, because I'm about to tell you what you can do to cut all these costs away. There's not enough emphasis on prevention, as I've already alluded to, because, of course, you don't get paid for preventing disease. You get paid for treatment. You don't get paid for prevention. There's a primary care crisis. Primary care crisis. Primary care doctors are quitting. It takes a long time to see a primary care doctor. ECG management consultants found that the average wait time was 38 days for new patient appointments in primary care. When my friend Amir Rubin went from Stanford to eventually running One Medical, he did studies at One Medical. It turns out One Medical saves money. Why? One Medical saves money because if you get people in to see a doctor, they don't go to urgent care and emergency care. Too much care in the United States is delivered in the highest cost locations: urgent care, emergency care. Of 253 metropolitan market and specialty combinations, only 16 or 6% had an average wait time that was less than 14 days. We have a primary care crisis in this country, primary care undercompensated, and primary care doctors overburdened. What to do today? Here's the answer of what you need to do. You need to make access to primary care easy. Number 2, get rid of high-cost providers unless they offer a discernible benefit. Many, many, many years ago, a hotel chain in Florida called Rosen Hotels said, "Why is our healthcare costs so high? Oh my goodness, we're using high-cost providers that are not offering a discernible benefit. Limit your network to companies, to providers who can demonstrate an economic benefit, an economic return." Number 3, many of the leading edge employers today, the larger ones, have begun to do direct contracting. As opposed to using Aetna or Blue Shield or Elevance, they say, I'm going to go directly to the health system and contract with you. This is essentially what Toyota did a gazillion years ago with respect to its suppliers. When you direct contract, you get 2 advantages. The first advantage is you leave out the intermediary and the fees and all the burden and administrative overhead. But secondly, a company that we've interviewed for the study we're doing said, we went to this health system in this city, and we said, we are going to meet with you every 2 weeks to talk about common issues. We are going to basically build a partnership. This is what Toyota did with its suppliers. It's what Honda did with its suppliers. It's what Boeing does with its suppliers. It's what you can do with your supplier of healthcare. We're going to have joint problem solving. We're going to have talking about what you need from us and what we need from you. We're going to close the feedback cycle so that we can engage in a process of mutual adjustment. And we're going to say, how can we jointly make our care delivery process more efficient and effective? What do you need to do as the provider? What could we need to do as the people sending patients to you? How can we work more together better? And of course, as the quality movement has taught us 1 billion years ago, what you do not measure, you cannot manage. And so therefore, we have to measure things besides cost. We have to measure access. What is your wait time to appointments? What is your prior authorization burden? Are we, in fact, treating you efficiently and effectively? What is the health status of the workforce? If I make you the general manager of the Kansas City Chiefs, one of the things you're going to measure on a daily basis is what does our injury roster look like? This is true if we make you the manager of the St. Louis Cardinal baseball team as well. What is the health status of our workforce? And by the way, who's accountable for making sure that that health status is moving in the right direction? And then finally, you want to follow the money. You want to follow the money. Basically, employers are putting money in to the system. And at the end of the day, some of that money gets delivered to the providers of medical services. Hospitals, doctors, producers of pharmaceuticals. But in between, where the money goes in and the money gets paid, there's leakage. If you aren't familiar with her, you should do a Google search for Montana Marilyn Bartlett. Marilyn Bartlett is an interesting woman, grandmother, hired by the state of Montana to fix their going broke healthcare system for retirees and active employees. One of the things that Marilyn Bartlett told me is that she said, I looked and saw that we had paid $4 million to a third-party administrator. And I found that of that $4 million we paid to a third-party administrator, only $1.5 million actually reached the providers. What you don't know, but some of you probably know very well, is that many of the third-party administrators, the TPAs, have made deals with the providers so that the EOBs that you're getting and paying money on is not actually the amount of money that the providers are getting, that there's in fact leakage, that they have negotiated discounted prices, which you are not getting the benefit of. Interesting. Where is the money going? Where is the money going? Follow the money is the lesson of the whistleblower in the $100 million New Jersey suit against Blue Shield and Blue Cross. We have come to believe, and I know this because I sit on the Stanford Committee for Faculty and Staff Human Resources, we have come to believe somehow that healthcare is different, that we can buy complex computer equipment, we can buy computer chips, we can buy electric power, we can buy all kinds of things directly and simply, but healthcare is different. And because we believe healthcare is different, we have not purchased it in a very interesting way. Many years ago, the CEO of Chrysler said, I'm paying too much for healthcare, it's raising the cost of our car. I'm going to take a couple guys from purchasing and send them off to change how we buy healthcare. Those two guys, who are now retired and I had the privilege of meeting, saved Chrysler $1 billion. And 6 months after they retired, it had all gone back, all gone. Because, of course, as I said at the very beginning, one person's waste is someone else's business model. One person's waste is someone else's business model. There are large organizations making a fortune with all of this waste and whatever. I'm going to end, and then we'll have a tiny bit of time. We have a little time for questions. I want to end with an interesting story. It's, of course, a true story. So some months ago, I got an email from somebody that said, you need to look at LinkedIn. I'm going to read you a LinkedIn post for a man named Bryant Lynn. I suspect no one in this room has heard of Bryant Lynn. Bryant Lynn is a clinical professor of medicine, entrepreneur, director of medical humanities at Stanford University. Bryant Lynn posted this on LinkedIn, which is in the story of Bryant Lynn, I think illustrates how to fix U.S. healthcare and what's wrong with it. I quote, I'm living in insurance hell, 3 exclamation points. I am a stage 4 lung cancer patient and advocate. As a medical school clinical professor, I taught a class at Stanford anchored around my own case, which was covered widely in the New York Times, CBS Mornings, and other media outlets. At least I could turn my misfortune into a little bit of good. Thanks to amazing advances in treatment with Tagrisso, made by AstraZeneca, I have survived progression-free until a couple weeks ago when my cough came back and the CT scan showed spreading cancer in my chest. I urgently need new treatment as my symptoms have all worsened. Aetna just denied prior authorization for potentially life-saving, prolonging treatment with Rybrevant, made by Johnson & Johnson. This is an FDA-approved therapy for my specific cancer and prescribed by one of the leading thoracic oncologists in the world. If my appeal is denied, what is going to happen to me? No need. Please repost and forward this message on any platform as widely as possible so I can get some insurance relief. In my 20 years as a primary care doctor, insurance has corroded doctors' abilities to treat patients as human beings. If you are Bryant Lynn, within 24 hours, the decision is changed. The dean of Stanford Medical School calls Aetna. Bryant Lynn reaches out to me. He's now a friend. I tell him who to reach at Stanford Benefits, the head of HR, the head of benefits. Aetna is called. But here is the sad part of the story. We still use Aetna as our third-party administrator. The person at Aetna who turned down Bryant Lynn still has their job. The person at Aetna responsible for this public relations disaster, by the way, Bryant Lynn's post received more than 500,000 views in 24 hours. This is not good for Aetna's image. Nothing changes. Nothing changes. If you are, this goes exactly to Eric's point, if you are connected, if you're a faculty, medical school faculty member, if you have access to the head of HR at Stanford, you'll get care. And if you're not, the story of Bryant Lynn is being repeated as we sit here, hundreds of thousands of times a day. And at the end of the day, all we are doing is driving up administrative costs, driving people at their most difficult time. I've talked to Bryant Lynn basically on the day of this message. And what I heard from this courageous man, who's, by the way, writing a book about living with end-stage cancer: fear, anger, sadness. The United States healthcare system could do a lot better. But in order to do that, we have to hold ourselves accountable. We have to measure access. We have to measure something besides money. Sarah Singer and I have an article in the Journal of the American Medical Association. When companies measure anything, it's dollars. It's not access. It's not postponed treatment. It's not how many hours I've spent on the phone with my insurance companies. We need to measure, we need to manage, and we need to hold ourselves accountable. This is a completely solvable problem, but it will not be solved unless we change. We have to change what we do. We have to change our vendors. We have to do what Marilyn Bartlett did. When Marilyn Bartlett went to Montana, she talked to her third-party administrator and said, I will need to become a better purchaser of healthcare services. I need to know prices. And of course, the third-party administrator said, I'm contractually precluded from giving you prices. And Marilyn Bartlett said the two words that made our president famous: you're fired. And the third-party administrator said to Marilyn Bartlett, well, you know, we have a contract. And she said, I have the Montana Attorney General. When Stanford University went to Aetna this year and said, can you reprice, take a sample of our claims and reprice them using the fees paid to the University of California, San Francisco, because most of our population goes to Stanford. It's a very high-cost place. Can you reprice this through UCSF? We were told, of course, no. We are contractually precluded from doing it. We still use that now. As I say to my friends on the committee on which I sit, which is the Committee for Faculty and Staff Human Resources, which is basically the Committee on Healthcare Benefits, which is now worried about a 12% increase in our medical care costs, and we pay over $500 million a year for healthcare. Nothing will change until you change. In the words of a fabulous venture capital firm that invested in a company that I also happen to be invested in, you cannot expect the organizations that have caused the problem to fix the problem that they have caused. We need new organizations, eMed being one. We need new organizations, and you need to be able and willing to hold the organizations that are doing a bad job accountable. Otherwise, I could stand up here 20 years from now, assuming I survive, and the story will be the same. Nothing will change until and unless we hold people accountable, and unless we demand better from this healthcare system. We have, according to this, 4 minutes left. I'm not supposed to take questions, but I don't do what I'm told, as you can tell. As you can tell what I'm told. So if anybody has a question, I can either give you 4 minutes back, or I will take a question from anybody about anything we've talked about. Yes.
Primary care, number one, you mentioned preventative stuff. Primary is prevention number one. You raved about Kaiser's model in the past. We talked, there's a lot of individual employers creating their own health centers to get access, minimizing that 42 to. What's in your view, if you have perspective, we work with a lot of the older gentlemen, the unions. How do you get them in the door? How do you change their behavior to get them engaged? Any thoughts on that? To get them engaged in preventative, besides, nobody reads their emails, promote. The younger generation, actually, we have apps that they can set appointments, they're doing it, but still concerned about the older generation of going in before it's too late.
Well, you mentioned something that I think is fabulous, and one of the things that depresses me on the days in which I choose to feel depressed is that, in fact, companies like SAS Institute and the on-site primary care was a trend for a while. And it's also interesting. I mean, Stanford in some sense has on-site care. We have a hospital. Unfortunately, the hospital charges us a lot of money too. But I think on-site care. One of the pitches that Amir Rubin made when he was running One Medical is he would go to the employers, he would sign up employers and say, look, we are going to provide you access. There's now crossover health. There are a bunch of places that are trying to solve through telehealth and through other ways, basically easier access to primary care. But I would take out the word primary. You need to have easier access to care. You have to be able to access care without spending hours on the phone. I did a study with Gallup. I'm a senior research scientist at Gallup, for whatever the hell that's worth. We used Gallup data to look at a very interesting thing. We are apparently the first people to estimate how much it costs for people spending time on the phone. And by the way, since most medical offices and since most, by the way, benefits offices only operate during work hours, 53% of all time spent on the phone with your insurance company is spent while the employees is at work. Direct cost, $26 billion. The indirect cost was $90 billion. What is the indirect cost? It turns out that if you separate employees into two categories, one, I've had to be on the phone with my insurance company, or two, I haven't. The people who have been on the phone with their insurance company, and this is controlling for health, are more likely to quit, are less engaged, are less satisfied with their job. So you're paying money for benefits, and because you have made it hard to access the benefits, you've actually wound up just pissing people off. So access is absolutely critical. How fast can I get an appointment? How fast can I get in to primary care? Yes, absolutely, on-site care is fabulous. We're out of time. It's perfect. We're out of time the same when we're out of questions. Anyway, I will be around. Thank you very much.
Please enjoy a short break, brought to you by our technology partner, Salesforce.
I will tell you the names of some providers and administrators and whatever that will solve every problem I have alluded to. I have to tell you, of course, I have an economic interest in all of them, but it's okay. This is a completely solvable problem. Well.